Hi, good morning. I am so excited to be here today, joining you, Barbara Bush, and Eric Schmidt. I work in social media with a large audience on social media, and I hear every day about the challenges of vaccine hesitancy and conspiracy theories that the audience is concerned about. I just want to give you some quick data points. To date, 30.5 million doses of COVID vaccines have been given in 43 countries, nearly 10 million in the US. But the greatest roadblock between us and herd immunity is a significant population that says they just don't want to take the jab. So to learn how we tackle this, I'm joined now by a panel of some very impressive experts. Cass Sunstein, the Robert Walmsley University professor at Harvard University, who is working on these issues for the WHO. Dr. Saad Omer, director of the Yale Institute for Global Health and associate dean at Yale School of Medicine. Dr. Claire Wardle, executive director of First Draft at the Berkman Klein Center for Internet and Society at Harvard. Dr. Stephen Thomas, University of Maryland professor of Health Policy and Management. And Dr. Kizzmekia Corbett, research fellow and team lead for coronavirus research at the NIAID's Vaccine Research Center. Before I kick it off, Dr. Corbett, so honored to meet you. Thank you for your work and helping us get out of the house sooner.
Thank you. Nice to meet you, and thank you for having me.
I thought I'd start with you, Cass. It's great to see you. You've written about the reasons people are reluctant to get the vaccine. Would you spell out what you call the 3 C's?
Yes. So there are 3 problems that people face in deciding whether to get vaccinated. The first is a lack of convenience. And the basic idea here is whether it's time or money or confusion about how to get there or thought about possibly unkind or disrespectful treatment, inconvenience writ large, inconvenience in the round can be a very serious obstacle. And there's reason to think that while it doesn't get as much attention as the other 2, which I'm going to get to, that inconvenience is potentially the largest problem, and the solution, the creation of an enabling environment, can overcome that problem. The second problem is complacency. There are a lot of people who think I'm healthy, I'm strong, I'm young, or I'm old, but I'm really strong and I'm going to die anyway, maybe in a long time, and I've had the flu a lot. Complacency is an independent problem. It isn't about conspiracy theories or anything. It's just a thought this isn't worth it. And there are strategies pointing to the life you save may be your mom's, or the life you save may actually be your own, that can address the problem of complacency. The third problem is described often as confidence. And what it means is actually a lack of confidence in those who are suggesting you should get vaccinated. And here the idea is that many people around the world and in the United States think it's going to hurt a lot, it's not going to work, it's going to cause side effects, something terrible might happen, and they're in it for the money. And that is addressable also, both by providing professionals who can show they've been vaccinated and they're themselves and they're trustworthy, or by creating a kind of set of, let's say, surprising validators. That is, people who can validate the wisdom and sense of getting vaccinated, who have something in common with the people who are mistrustful, who share their identity. A lot of our cognition is based on our sense of identity, and that's both a problem and also a fabulous opportunity.
Convenience, complacency, and confidence. Dr. Omer, this isn't new territory for you. You have worked on issues of vaccine hesitance even before COVID. So can you give us a sense, in the past, what kind of strategies have proven effective to increase vaccine uptake?
So there are different levels of interventions that have helped, from structural interventions like making it easier to get vaccinated than not vaccinated. So creating a pathway of balance of convenience that leads you towards vaccination. For example, having procedures such as that nudge you towards vaccination by making it easy, by increasing incentives or providing appropriate incentives for people to get vaccinated. But at the interpersonal level, at the healthcare provider level, there have been a few promising strategies that have come up. They include something called motivational interviewing that has shown promise. And then the other one is presumptive communication. Presumptive communication works through verbal defaults, where you say, if someone comes to a clinic and you say, should little Johnny get vaccinated, versus it's time for little Johnny to get vaccinated. So just these verbal defaults have been shown to be associated with higher uptake if you presume vaccination, which is routine. But that doesn't take away the choice. The other part that has been promising in interpersonal communication is motivational interviewing, going through the reasons for those who are not persuaded by the initial presumptive communication approaches, going to the next phase where you elicit the reasons, use narratives to motivate people to vaccinate. So in addition to what Dr. Sunstein described, some of these strategies have been helpful.
Dr. Corbett, let me turn to you and ask, one of the concerns I hear frequently from people who message me on social media, people I talk to, is if they're concerned, they think that this vaccine was rushed. And isn't it true that you have been working on the technology involved in this vaccine for years? And do you find that messaging that is helpful in increasing trust? And if not, is there a specific message about your work that does connect?
Yeah, when people say that the vaccine was rushed, I think that one of the things that we all are dealing with right now is the fact that the general public, this is really their first time that they've seen a vaccine or any drug really be developed before their eyes. And also some of the terminologies that we've used around the vaccine development, such as warp speed, et cetera, really don't take to the general public well. And so, yes, reminding people that coronavirus vaccine development did not start on January 10th when the sequences of the virus came out last year. But in fact, we've been researching, us in our laboratory and laboratories around the globe have been researching how to make coronavirus vaccines since the onset of the SARS-1 epidemic years ago. And so all knowledge that we drew upon from those studies, and then particularly in the last 6 years since I've gotten to the Vaccine Research Center, really trying to understand how to make a really good coronavirus is what's happening right now. We were really able to monopolize on that knowledge and also on a revolutionary vaccine delivery platform by way of mRNA. And so you have these two things, right? You have this novel virus with this new vaccine platform, and you have the general public literally watching every single step, may it be by headlines or social media along the way. And so it is reassuring to people to let them know, look, we started this years ago. Here are the publications that show all of the data. Messenger RNA did not go into people on March 16th of last year. Actually, it had been in humans and proven safe by way of Zika vaccines, et cetera, prior to that, and really laying the foundation of the history of the vaccine development. And also reminding people that while Operation Warp Speed does have a mission to get a vaccine to the general public quickly because of the dire circumstances here, by no means have any of the steps along the process been compromised or been taken irresponsibly. In fact, the purpose of Operation Warp Speed was to really have a solid, unified effort across multi-institutions, whether it be companies, federal government, et cetera, to say, look, this is a job we need to get done. Let's organize and strategize and also finance so that we can do this quickly and safely and effectively.
Dr. Corbett, I'd like to follow up with you about some of your work outside the lab and in the community. Black Americans have a pronounced hesitancy often to the vaccine. They're being especially hard hit by COVID and at the same time have historically valid reasons to be mistrustful of the US medical establishment. Now, I'll tell you that one woman I communicate with is a small business owner in Texas, a Black woman who said, my brain says to get the vaccine, but my brain also says they're going to use me as a guinea pig. And so you have said that to rebuild trust in the Black community, you have to do it brick by brick. How are you doing that?
You know, really, I think that I personally started laying the foundation even as far as undergrad, where I really started to combine my basic biological sciences research with health disparities research. And so from that standpoint, doing health disparities research in Baltimore City, I really got a grasp on really how to engage the community around health disparities and disease outcomes. And so really what I'm doing now is just going back to those roots and utilizing my outreach, so to speak, to talk to the community in very lay language and really to remind people that vaccination is a choice. And what our purpose here from our side of things is to make sure that people have the information available to them so they can make an informed decision. And I do want to remind people that while the media does, like to say that I speak solely to Black communities, but there are several, multiple disenfranchised minority communities in the United States, actually, and also globally, Native American populations, people of Hispanic backgrounds, et cetera, that we also talk to have the same types of concerns. And so, the first step, I think, for us is to really lead with empathy, really put ourselves in those shoes. I like to think that, like, if I wasn't a scientist, I would just be a girl from rural North Carolina, a Black woman who might not understand the science and the biology and also the development processes of these. And so I like to put myself in those shoes and then work my way up from there. And the first step is to say, I understand, because I absolutely and wholeheartedly do. And then the second step is to inform. And then I find from the informant standpoint, you really have to be specific, asking questions and guiding your answers to really specifically answer what people's concerns are, I find to be very helpful.
Thank you. Dr. Thomas, you've been working on these issues for years. Long before COVID, you developed the community-based intervention that works with barbershops and beauty salons to deliver public health information to the community. Would you explain how and why your approach works?
Well, first of all, good morning. Actually, since March, I haven't even been to the barbershop. You see, I have my head covered here. And you have to understand that in the Black community, barbershops and beauty salons are places where social norms are set. No self-respecting barber would ever say, I'll get you in and out in 15 minutes, okay? It's an all-day affair. It's a community gathering place. And it's a place where many years ago, I witnessed a barber have more power than a physician. I saw a man sitting in the chair as people were listening to the stories that are talked about in the barbershop. And the gentleman pulled out a bottle of pills and said, the doctor told me I need to take these the rest of my life. These were hypertension pills. And the barber said, you know, Joe, if you take those pills, you won't be able to keep up your obligations. Do I need to explain obligations to anybody in this audience here? Okay. So I recognize that he's not going to take those pills. And his doctor has no idea there's somebody in the community with this kind of influence. Yes, there are drugs, hypertension drugs that can cause erectile dysfunction and other things that could be embarrassing. And I said, what if that barber was a partner? What if he said, hey, Joe, if you're having side effects, tell your doctor, they can change things. And that began our work around hair, health advocates in reach and research that we've started about almost 20 years ago. And it is a recognition that you have to meet people where they are. You have to go where people are already trusted. And so we believe that really getting back to basics, getting back to public health basics is the key. And that barbershops and beauty salons can be places where we literally bring the health services. In the opening, Mr. Schmidt talked about telemedicine. Well, if we can bring telemedicine to a small village in Burundi Why can't we bring telemedicine to a Black barbershop in inner city Baltimore or in Prince George's County? And we have modeled these things. We have modeled how do you bring these services into the most humble place in the African-American community and change minds, change attitudes, change behaviors. And so our barbers have been trained. Specifically, we launched with a focus on colorectal cancer screening. And if I can talk to you about colonoscopies, I could probably talk to you about anything. But we bring the gastroenterologists into the barbershop. We've done PSA blood draws and rectal digital exams in the barbershop, Big Tom's, full service. So the point is, you have to build trust. That's the bottom line. And also in the opening, the founder talked about the insurrection, what we're going through in this country right now. And for many Black people, guess what? That's the America we know. We're seeing the real America come out. We're not surprised. And we should all be ashamed by that it's taken this to feel the suffering of a community that before the pandemic was already dying before their time. And so now the pandemic comes and they're saying, why do you care about us now? We've had the diabetes, the hypertension, all the chronic diseases. Where were you then? We've got to rebuild trust from the ground up. We've got to give voice to the community's suffering. And we have to be patient. All that we've talked about so far, we're asking them to absorb a lot of information. And it's at a very high level of complexity. And no one's talked about the fact that we have the biggest microphone in the world being the most common source of disinformation. How can a local community overcome disinformation coming from the White House? If we don't acknowledge the blowback, the pushback that's out there, we're not going to be able to meet the challenge. I love Warp Speed in terms of how they did it. They paid the companies in advance to develop the vaccine before it was developed. They paid the companies for a product before the product existed. Success. But why can't we get the vaccine into the arms of people? A vaccine without vaccination is an exercise in futility. We did not pre-position resources to get the communities ready. We did not prepay for an infrastructure for the distribution of the vaccine. We did not prepare the community and educate them to get ready. Now they're saying, where do I line up? And there's total confusion. It's a very fragile moment we're in right now. I think we can get to a better future through health, through this public health frame, but the dynamics are such that criminal justice and all these other issues are also taking up oxygen.
It reminds me a bit the way you just, it reminds me a bit of political organizing. What you're talking about is going block by block, acknowledging people's concerns and needs, hearing the community and bringing the experts to them. And I'd love to come back to you in a moment to ask you how we scale that idea, how we address these topics and scale them. I just want to bring Dr. Wardle into the conversation because there's another piece of this, which is online disinformation, and that's what you study. There's a wild world of vaccine misinformation and disinformation online, and I'm inundated with the conspiracy theories. I wonder if you would describe the landscape of misinformation for folks who don't spend their days in those dark wormholes. How organized is it? Are there consistent themes?
Yes, absolutely. Misinformation and conspiracies is a real problem. We've known for a long time how organized anti-vax communities are. And certainly we are seeing wild claims about microchips and Bill Gates, the use of fetal tissue, a whole host of kind of dark spaces pushing this kind of content. But I think for the conversation that we're having, we also have to recognize that there are a number of people who just have questions, and misinformation flourishes when there's a vacuum. And I think as we've been having this conversation, we have not been prepared because we have not answered some of those basic questions people have about even how does a vaccine work? You know, how long is it taken to be developed? All the things that we've talked about. And so when people have questions around infertility, I'm seeing a lot of young women saying, I'm very worried about getting vaccinated because where's the evidence? I'm worried it's going to make me sterile. Now, that's the kind of thing that we could have preempted. And so I wouldn't say that that's misinformation as such as people asking questions. People say, well, why does Pfizer have indemnity? You know, and the work that I do with First Draft is we monitor misinformation conspiracies, but then we look to see what kind of quality information people find when they Google that. So, for example, we work with journalists. So if I Google COVID vaccine death, what do I get? I get a lot of professional news sources on Google telling me that somebody has died, which we knew and we were expecting because of the way vaccine rolls out, because with people of a certain age, it's likely to happen. So we talk about misinformation, we talk about conspiracies, and yes, we have to be concerned about those anti-vax communities, but I'm actually more concerned about ordinary people who normally get the flu shot, normally immunize their children, but saying, well, I've just got some questions about this particular vaccine. And when you go to YouTube and Google with those questions, what do they find? They're not finding quality information. And those vacuums are being filled with conspiracists who are taking advantage of the vacuum. So there's both of these elements that we have to take seriously and not just say, oh, goodness, everybody's concerned about microchipping. And I think to go back to this current moment, we did some research last summer about the key narratives around vaccines, not just misinformation, but the narratives that were being shared. And the biggest narrative is around liberty and freedom, not about safety and efficacy. It's about liberty and freedom. So when we consider the events at the Capitol last week, there are large proportions of the American public now who are not trusting the government. They don't trust the platforms because of these speech issues. And so this question of, is it going to be mandatory? Will I be allowed to fly? Will I be able to go to my workplace? We have to look at the online conversations so that we can respond to them in a way that's responding to people's concerns and questions. And I think if we just focus on the conspiracists, we're not thinking about the ways in which these vaccines are being discussed. And certainly in terms of being prepared for next time, there's a whole host of things that we should have done over the last 10 months that we didn't in terms of communication. Yes, lots of resourcing was given to building the vaccine, but we did not invest exactly to the conversations we're having today in working with communities around these basics of, we knew what some of these rumors would be. We should have cut them off ahead of time before the vaccine was rolled out.
May I follow up quickly with you? We have a very full panel, so I'm trying to keep it moving, but I do want to ask, there's some very specific advice I've been given when it comes to speaking to the vaccine hesitant. For example, don't repeat the conspiracy theory or any aspect of it. Try to discredit the people who've provided this conspiracy theory. Can you discuss any specific strategies or language people in the audience should know to use when addressing the hesitant or the conspiracist online?
Absolutely. We instinctively think that we should take the falsehood and reject the falsehood and focus on the claim. But actually, I was talking about the ABCs of disinformation, something Camille Francois talked about, which is actors, behaviors, content. We should be actually focusing on who these people are who are pushing these conspiracies and what's in it for them. Saying, you know what, that person who's trying to tell you not to get vaccinated, let's look at their website. They're trying to sell health supplements. There might be a financial reason that they're pushing that, because it doesn't matter where you sit on the political spectrum. It doesn't matter how well educated you are. As a human, none of us want to feel like we've been manipulated. So actually, when you focus on the tactics and techniques being used to push false information, it makes people feel less independent. They don't feel like they've been attacked because you're like, see, you were manipulated, and it allows people to go, oh, okay, that's interesting. Whereas if you just lead with the piece of the content or the claim, people, as we know, around confirmation bias are more likely to feel judged by that. And to all the conversations about empathy, when you're talking to a family member who you're worried has been sucked into this, it's about listening, it's about empathy and saying, I see these rumors too, I'm worried. How is it affecting our community? We need to use that kind of language. Us, we, not them, you're wrong. So there is a science to how to talk to people about this kind of content.
Cass, I'd love to go back to you and ask, I know that you're working with the WHO, developing, I think, guidelines for leaders around the world. Would you share some of the guidelines you're working on or your lessons on a global scale?
Yes, thank you for that. So one of our key suggestions is that in responding to the question of vaccine hesitancy, we need to be thinking of targeting. Meaning, who are the vaccine hesitants and what is the source of their hesitancy? So for a number of people, and I think this is an underrated part of the problem, it's just they don't know where to go. They don't know how long it's going to take. They don't know if it's going to be expensive or trouble. If you can create an environment which is enabling to people, you can dent the problem, and denting the problem is very good. For people who have questions or who are scared or something, often those people actually can be helped by just making it convenient for them to get vaccinated. It's around the corner. It's really easy. You'll be out in an hour. Now, that won't solve the problem, but it will dent the problem. That's our first suggestion. The second suggestion is that social influences really matter. And the extremely instructive tale of the barbershop is a brilliant case study in this. So what do people like you and people you talk to say? And what do they do? We know that if people think that the social norm is in favor of getting vaccinated, that can create a self-fulfilling prophecy. And we also know if the social norm isn't quite there yet, if there's an emerging norm in favor of getting vaccinated, if that's what people are starting to do or doing in increasing numbers, that can be an extremely effective method for creating a self-fulfilling prophecy. So that's targeting areas in which the social norm is cutting in the wrong way. And you can help change that by publicizing what's starting to happen. If the problem is one of distrust, I love the comment just made about you don't meet the argument by saying the terrible thing that you're describing isn't real. Because as was said in a great old book called How to Win Friends and Influence People, you can't really win an argument. That's very hard, but sometimes you can get people to want to agree with you. That's a very brilliant insight. And if people are feeling distrustful, then if you say, well, you know what, your neighbor or the person you find most credible, they got vaccinated yesterday or they're planning on doing it tomorrow. So the emphasis on it's an ugly word, validators, but validators who are like you in the sense that they have characteristics that you consider kind of stamps of credibility. Those surprising validators often can work on this very different category. That is the category of distrust. Now, these three categories, it's inconvenient, I'm not scared, that's the second. And third, I don't trust them. They have to be helped in very different ways, and to treat them as, agents with respect rather than as objects of some plan is a really good idea.
I'd like to pick up on something Professor Sunstein said and turn to you, Dr. Omer. He talked about validators. Traditionally, in the conversation around vaccines, we've looked to health professionals as the validators, as the trusted messengers to encourage people to feel safe. One of the unusual things now is, according to the Kaiser Family Foundation, there's about the same level of vaccine resistance among healthcare workers as there is in the US, as there is in the general population. Do you have any insight into how to tackle this problem?
So that's a really good point. First, to highlight your initial point further, I've had the privilege of working in various parts of the world on this topic for several years, for a couple of decades, and there's a lot of variability in terms of why people are hesitant about vaccines or refusing vaccines. But there is one constant, and the constant is that the most trusted source of vaccine information is the healthcare provider. And so that's something to keep in mind. And even, one of the initial insights that, slightly surprised me a couple of decades ago was that people who were refusing vaccines were also rating their healthcare provider the highest in terms of trust in vaccine information, even though their overall trust in the government and healthcare providers was lower. So now we find ourselves in a position where our main focus or our best tool of delivering vaccine information and trustworthy vaccine information is, if you will, compromised by the fact that there is vaccine hesitancy in this specific group. And we've probed it a little bit, and there are a few sources of this hesitancy. The first thing is there's unfamiliarity with the content itself. And it was mentioned earlier that there is, even though mRNA vaccines and all the platform technologies that are being now used for COVID-19 vaccines have been around for a while, and people have looked at these kinds of things and worked on this kind of stuff for a while. The perception is because they're not used in licensed vaccines that they're really new. So that's one thing. There is that unfamiliarity, and there is the so-called information deficit situation where this empty real estate is being occupied, even in the expert community, even amongst frontline physicians and other healthcare providers. This place is being occupied by lack of information or misinformation. So that leads to not just misinformation, but lack of trust in information. So in this kind of a situation, and a lot of other cases when there are so-called non-expert audiences, the information itself is not always the mainstay of interventions. But in this case, because there is desire for information and educational intervention, going through the details of how the vaccines work, why we think they're safe, what are we doing to make sure that they remain safe, they have promise. And we have initial data from some of the other vaccines, for example, in pregnancy, that suggests that is a promising strategy. The second thing is we need to empower our healthcare provider in being good communicators. And so we need to remember that even as we build vaccine confidence in healthcare providers, we need to empower them to be our, the tip of the spear, if you will, for these kinds of interventions. And we need to think about it at scale. So one of the things, unfortunately, in public health is that we do a few too many pilots. This is not the time for pilots. This is the time to go to scale. And there are approaches that can be used to go to scale through training, through CMEs that focus on these kinds of continued medical education, for example, and other approaches that can empower healthcare providers to be armed with the information that gives them confidence as healthcare providers, as gung-ho supporters of vaccines, but also empowers them with evidence-based approaches, some of which was discussed. And a couple of other ones that I would highlight that have shown promise in addition to focusing on trust, building social norms, et cetera, is speaking to people's values. Dr. Wardle talked about liberty, et cetera, that has come to surface in online conversations. Our work has shown that a lot of vaccine decisions are moral decisions that are based on values. And some of the values we have isolated that are influencing people's decisions include the so-called purity value, as well as, in terms of the contents of the vaccines, et cetera, but also in this specific case, liberty values. So speaking to people's values, and we have done some online experiments that suggest that there may be some promise in having specific messages that speak to people's liberty. And they can be deployed at the mass level, but also at the healthcare provider level. And the last thing is that often when we talk about situations where the disease salience is high, meaning everyone is, we have COVID-19 all around us 24/7, there can be this fear-induced paralysis where people, feel paralyzed in terms of not being able to do much about this overwhelming possibility of getting impacted by this pandemic. So then they start discounting information, and this is a reasonably well-known phenomenon. And one way of dealing with it is to increase self-efficacy and response efficacy, meaning that you can do something about it. You can, when your turn comes, get vaccinated, or you can wear masks if you're looking at the broader approach. But then if you do something about it, it works. So the response efficacy. Coming back to healthcare providers, these pathways work on both sides, the healthcare provider themselves, but also empowers them to communicate more effectively. So it increases their self-efficacy in terms of recommending vaccines. And then you can work on response efficacy. If they recommend vaccines, their patients are going to be more protected and will be less susceptible to disease. The good thing is that there is a body of knowledge and information that is out there. And from behavioral science to community-based interventions, like working with the communities, like working at barbershops, like working at other community-based situations. The key is to now compile it, and there have been compendiums. The one that Dr. Sunstein talked about, I have a privilege of being a part of that group as well, has produced a toolkit. Another set of tools have been produced with Dr. Wardle's work and UNICEF that is available, that we have compiled. Now the key is to scale that up and do it at scale, not at the pilot level, if I can say so.
Thank you. Dr. Corbett, let's take it back to you. I follow you online. I see what you tweet. I'm curious, we all know that the social media includes a lot of dangers and it's not always benefiting our society, but it is a great way to communicate directly with people. And I wonder, how do you work to combat misinformation through social media, or do you think it's just not a good venue to tackle this?
Well, I absolutely think that it is a great venue to tackle misinformation because by and large, that is where the misinformation is spreading. It goes without saying that the data shows that misinformation spreads like wildfire on social media, where the facts do not. I don't necessarily tackle misinformation specifically on social media, so to speak, unless I'm specifically asked to do that by someone via a question about the vaccine. What I do is just tell the truth about the data, really specifically in regards to the coronavirus pandemic, and also in the vaccine development. And I try to be as upfront with what data might be coming out, what data just published and comes online, and speaking to data as it comes out from a very scientific perspective, but in layman's terms. And I think that really helps people to feel like they are embedded in the process. Because as I said, this is the first time that anyone in the general public has seen a vaccine being developed before their eyes. And so helping them to feel like they are a part of the process really does, I think, help to build some trust.
Thank you. Dr. Thomas, on Twitter, your mantra seems to be expose and educate. So building on what Dr. Corbett just said, what about the vaccination process do you think needs to be laid bare for people to feel like they understand and they're informed enough to make good decisions for themselves?
Well, first of all, I'm glad I have at least one Twitter follower. That's excellent. and
I'll
so
get you
that
more.
moniker, that tagline, expose and educate, is simply this. I think we need to educate the community. We need to be there and listen. We're really asking a lot of them, and we haven't been there for them during the health disparities. So trust is a calculated risk. And I don't think our job is to disarm the community. Their hesitancy has been earned. And we as health professionals need to go back to our institutions and share what we're learning from the community. If you don't have a health professional, it's hard to then have trust in one. And so when our health professionals are also confronted with that history of research abuse, some of them are not aware of the magnitude of the Tuskegee syphilis study and its implications and its shadow. But here's the reality. The men in the Tuskegee study, the longest non-therapeutic experiment on humans in the history of medicine and public health, had syphilis. The egregious harm that was done to them was that they were denied treatment when penicillin became available. They were denied treatment. So the real lesson from the Tuskegee study now is to ensure that African Americans and other vulnerable populations have access to this vaccine. So it's the ongoing conversation that has to happen, and the recognition that our systems are still broken. The death of Dr. Moore and her Facebook Live story says that people are really scared going into those systems, that somehow their lives will not matter. We've got to address that at the core of our profession. And so I think that the conversation just cannot be about roll up your sleeve and get the vaccine. It has to be, why do we care about you as a person? Why do we care about your communities? And what are we going to do to address the persistent health disparities that still exist?
Thank you. Well, it is trite but true that vaccines don't save lives, vaccinations do. So thank you to all of you for your work encouraging uptake, and thank you for being here today. And to Schmidt Futures, I throw it back to you, Barbara, and our hosts.